A few statements just starting out. One, what a pleasure it is to be here, to be in a room of neurocritical care physicians. Because I've been in this business a little while when you guys didn't exist. When Andy came and joined us at Pitt, and we started building a neurocritical care team, and so the concept of team building and unique relationships. Now, I'm a neurosurgeon, I'm a vascular neurosurgeon, so I'm the guy with the big problem and all the questions. So early on, one of my themes was just measure it. I don't want to make any assumptions. I want to know what the information is. So as you go through the talk, you'll see me talking about just measuring it. And you'll rapidly see that my name isn't really Howard Yonas, it's Mr. Gadget. Because I've just accumulated every gadget I can find and in my effort to understand a little bit better what that poor sick person is doing in that bed. And I just don't want to make assumptions. So the goal I was given was something about CPP, and CBF followed it. And I'm thinking, how did I ever accept that? Because CPP isn't what we're after. CPP was a way of saying something about what you thought blood flow was. It's a difference of these two pressures. What you always wanted and what you needed was CBF. CBF is the critical variable, as we've heard about, and I'll explain again. Just the same as Andy, you just want to measure critical functions that are the factors that are impairing function. I want continuous data. And like Andy, I want it non-invasive, I want it readily available, and as our government would want, we want it inexpensive. And of course, PET is this fabulous tool. It's a wonderful tool. It gives us a lot of information. However, it's not very mobile, it's not very accessible, it's not very friendly, it's not very inexpensive. So how do we get around the problem of not having a portable PET scanner at the bedside and frequent studies? Well, we do it by making multiple measurements. Perhaps information streams that are simultaneously looking at different parts of the elephant. And just looking at any part of the elephant by any one of these toys gives us a small piece of the question. So the challenge is to integrate various kinds of data and to give us the picture of the elephant. Now, you guys are going to like this because first and foremost in my technology stream is you. It's the physician. It's the physician who's at the bedside, who's looking at the patient, who has all these numbers and is trying to make sense out of them. So first and foremost, we don't get rid of the doctor. So you have job security. Just thought you'd feel better about that. So after, the surgeon does his fancy thing and he takes out some big mass lesion and the brain is still swollen, the patient's still unconscious, they still look like the Dickens. Gosh, we'd like to know some things. We'd like to know what's the ICP. We'd like to know CPP. We'd like to know CBF. We'd like to know oxygen metabolism. We'd like to know electrophysiology. I'd like to have an EEG. I like spreading depression data. I want SSEPs. Why are all these things relevant? Well, because these are the driving variables that we just heard about that are part of that critical equation. ICP, that's easy. A little baby, you put your finger on the fontanelle and you've got ICP. But for our patients who are in the ICU, we stick catheters in, we stick solid-state monitors. There's a really interesting discussion today I wasn't aware of. I have always put a catheter in the ventricle and used it to monitor as well as drain. But a lot of people feel that maybe we just want to put a solid-state monitor in. Interesting discussion that probably half the centers around the world don't drain the ventricles. I wasn't aware of that. Provide information about the intracranial compartment. But ICP doesn't tell us what the driving forces are that are getting us into trouble. It doesn't tell us if the flow is high. It doesn't tell us if the flow is low. It doesn't tell us why the ICP is up. And what the ICP tells us is what is the end result of all this havoc that's been going on. And we really want to know what preceded the havoc, and can we intervene in some way to slow that down. Some of the constructs we carry has to do with autoregulation, and we have this idea that CVF is going to be very stable over a broad range. But in reality, in our sick patients, it's probably very rarely like that. Or if it's like that in part of the brain, it's not like that in the whole brain. Very heterogeneous problems in head trauma. So can you make any assumption about autoregulation or the integrity of it? Can you make any assumption about if you change blood pressure, what's going to happen to blood flow? You can't. You can't make any assumptions in a sick patient with a swollen brain where autoregulation's gone, blood-brain barrier is open, all the physiology is disturbed. That's why you can't, that's why you have to measure it. And this is sort of the picture we always see about autoregulation and the failure of autoregulation, and I think of that yellow part is the slippery slope. Now, whether it's that slope or it's more of a gradual slope, but when the patient's on it, the basic constructs are you're maximally vasodilated. If you're maximally vasodilated and you raise the CO2, nothing's going to go up. And you're going to be blood pressure dependent. As you lower the blood pressure, flow's going to fall directly. As you raise it, it'll go up. And so as you play with the physiology, and that's the other part of this story, is you got to kick the physiology, you play with it, you drive the CO2, you change the blood pressure, we give various drugs. We become physiologists when we look at more than one data point. When we look at not just where we are at baseline, but how does it respond to our challenges as we're messing with this person? So blood flow, a topic for tonight, tomographic versus focal. I don't know if any of you know, I've done a little bit of work with this xenon stuff, like 30 years of my life, own nothing. And at the moment, we're not FDA approved, but there actually is another effort to get there. So why would you want tomographic blood flow if you had it? And I think this information is useful to give you a construct of how you think about using focal flow. So if you had just this picture, and that's a ventriculostomy, where do you put your monitor? Where's the problem? Do you know where the problem is? If you had a flow study, you look at that and say, wow, there's a whole bunch of that is below 0, or at 0, below 8 certainly. That's core. So do you want to monitor in the core? Well, of course not. You want to monitor in the penumbra. You want to know, so how do you know where to put your probe if you don't measure physiology first? What's the validation? What's the validation those numbers were real? Well, it's because when they're that low, that's what happens on the CT scan 12 to 24 hours later. So flow drives the phenomenon. Those flow values absolutely predictive of core. It's going to be dead. It is dead when you saw that patient. And where do you put the monitor? Well, it's really hard to know where to put it. Now, if you only have a single probe and you're just going to put it someplace, you know, I'm struggling a little bit on how you utilize it. And what questions can you answer? A single probe, put probably not where the injury is. If I got a big contusion on the right and have operated, I'm going to put the probe on the left. Doesn't make a lot of sense, but we often do that. But if you've done that, how do you interpret that? And you can only interpret it if you're measuring things that are global physiology. You're not trying to sample what's happening next to that clot on the other side if you put the probe on the other side. So what kind of things might be global? Here's a young lady. She delivered a baby, and she has a big intracerebral hemorrhage. Blood pressure is 175 when she hits the unit. Well, everybody tells me that's too high a pressure. We have to lower that. Is that right? Can you lower it? And we all know that now it's no problem. We can just lower that pressure because we've got some PET studies to tell us it's not a problem. You can lower that pressure as low as you want to go. And we're doing a study now lowering it to 120. Is that right? Does that apply to all patients? Is it related to the size of the clot? Is it related to the youth of the patient? Is it related to so many other variables? Because do you think that patient has a raised ICP? Is that just a focal phenomenon? Because when I lowered the blood pressure and looked at the blood flow, where did the flow drop? And it dropped profoundly. It dropped profoundly a level above, and it dropped profoundly all over the brain. So if I had a probe on the other side, and if I had qualitative flow, and I dropped the blood pressure, and the flow by a qualitative method fell by 30% when I dropped the blood pressure, you'd say, well, wait a minute, that shouldn't have happened. That should not drop. We should be autoregulate. We should be able to accept the lower pressure without impacting blood flow globally. So I'm trying to think of scenarios where a focal probe tells you about a global phenomena that you're trying to be sensitive to. Here's another patient, gentleman with some trauma, older fellow, clot, high ICP. CPP is now compromised. We're raising his blood pressure to jack up his CPP, right? We know that's what we're supposed to do. That's his flow study. Now he's in heart failure. Now his heart's sort of weakening. He's getting a little pulmonary edema. We're jacking his pressure up to maintain cerebral perfusion pressure. Is that right? Is that what he needs? Are we hurting him or helping him? So here we brought his blood pressure down significantly, took the dopamine off, and repeated a flow study. Tomographic, all over the place. Flow, in fact, goes up a little bit. Didn't go down at all. What do we do with that? Did we really want CPP? Is that what the measurement was we wanted? It's an index, an indirect index of blood flow. Wouldn't you rather have blood flow? And where would you measure this? This ought to be a global thing. Perhaps a probe anywhere on the brain would give you some index of safety, of lowering blood pressure. These are concepts of how do you use focal measurements indiscriminately placed to tell you about global physiology. So if you don't have this kind of tomographic stuff, you're stuck with multiple modality monitoring. And that's why I say I'm Mr. Gadget, because, gosh, I have gadgets. And I guess you got to be a neurosurgeon to be able to just play with all these things. So I just keep putting in probes in people. But there is a limit to how many holes you can put in somebody's head, by the way. And so if I have one hole, perhaps I can put down 2, 3 probes if I guide them, and we designed this with Hummingbird folks and put a few hundred of these in over the last few years. And it gives you access to multiple modalities. And then I've been blessed by using the technology that Dick Moberg put together, and it gives me the ability to integrate all this stuff, because there's nothing worse than walking in a room with 5, 6, 7, 8 monitors all flashing, and the nurse says, well, I think this one was different a few hours ago, or that one changed. Or, it's like, but where's the data? How do you know? How do I know what the blood pressure happened at the moment that happened? You can't deal with that data unless you integrate it and put it on a single storage system. So as you go to more complex physiology, you have to be able to grab it, access it, review it. And if you're in a medical center, you'd like to learn something from it by being able to put it on a big server and then come back and really study it and figure out what was going on. So the system puts out information like this, and it integrates flow and ICP and all these oxygen variables, and it's really very nice. And you look at it, that window, you say, I can see that blood pressure dropped, flow dropped very dramatically, and I learned something. And that's useful. But it's not as useful as if you take it the next step. Because I can't sit there at the monitor and look at it continuously or scroll through it continuously. We got to go one step beyond, and we have to integrate the physiology. And that's where this fellow, Mark Krasberg, who's a physicist, who joined us from University of Wisconsin, and he comes to this world with a new concept. He's not burdened with any preconceived ideas of mathematics and data handling. He has a very creative mind. And he gives me something like this. Here's 12 days of data, and I've got blood flow, I've got MAP, I've got oxygen, I've got ICP, and it's interesting. The blood pressure, this is a patient who dies in 12 days, of course, and oxygen right to death remained extremely stable, and ICP went down, and then it rose up paradoxically high, or not paradoxically, but appropriately high as blood pressure went up in response, but blood flow went away. So this is invasive monitoring. But if you're going to put a ventriculostomy in a patient, which I've always done, well, then I put some little side probes out, and I've got a whole lot of information from that kind of a paradigm. And so the next kind of question is, you got all these data streams, and you look at them and you say, but are they really locked in time and space? Because one is the radial artery, I'm sorry, and one is oxygen in the brain, and they all have different response times and different arrival times of blood from the heart to the brain. And so what you really want to do is sync all that data, bring it into sequential, into absolute lock time, so that you can do a correlation coefficient. You can actually see if autoregulation is absent, if flow superimposes on MAP perfectly, if exactly autoregulation is totally gone, correlation is 1, and then you can do autoregulation curve down below, and there's all your discussions about autoregulation. And theoretically, you can just keep doing this continuously at all times and just have the continuous processing. And so here's another patient, days of data, but just look over on the left, and you do the correlation coefficient early on between MAP and CBF. This is invasive monitoring again. But the correlation coefficient went to 1, total loss of autoregulation, those first few days of monitoring. And then it uncouples so that there is no relationship, and it goes back to 0. So in this patient, they lost autoregulation between what we were doing. They regained autoregulation, and you can see it and monitor that. It seems like that's the kind of data that you need to be able to say, now I'm going to intervene, I'm going to see it early, I'm going to do something, and try to recouple. I've had the privilege of looking at the Syrox technology with those kinds of analytical tools. And so if you look at MAP versus Syrox, you get some amazingly tight correlations, visual correlations. And you can do tissue oxygen, and we got some really nice correlations, visual. And ICP with the Syrox blood flow, looks like we're talking about the same business. Those are all, to me, validation studies. Okay, is this real? Is it physiology? Can I work with it? And just for the fun of it, here's MAP and ICP. That's not the Syrox, but understand when MAP directly converts into ICP pulses and raises, autoregulation is totally lost. The box is operating as a single unit, and you got a very dysfunctional brain, not just where your probe is, that's the whole brain, when it's cycling directly with ICP. And so then we can do these correlation kinds of coefficients of MAP and Syrox, and we get patients that have periods of very high correlation. And here you can select some very high correlation periods, and you can see that they're talking about the same physiology if you window in and blow up that interval of a few hours. And other areas where you don't have direct correlation, which is autoregulation. Patients sort of going in and out of this kind of physiology. So the last thing that we're struggling with and we're working with is using the Syrox during carotid surgery. And I've done one case, and it should be a good model to be able to isolate the vessels, what I'm looking at. And so here was the recording of the patient that we did, somanetics and the Syrox, and then the Syrox oxygen. So 3 types of measurements stacked. And so we really are seeing significant changes in the Syrox blood flow, correlates with the somanetics blood flow. And the things we need to talk about or think about and sort out over the next year or so is exactly where that measurement is how much of that is in the scalp, the skull, how much is in the brain. And as we play with the different vessels that feeding the area, we'll learn more about that. So the Syrox provides evidence that it is a valid non-invasive monitor of flow. It's sensitive to all the physiological variables. I think we need more clarification about exactly the proportion of the signal that's coming from where. We need to sort that out. And what's our future? We need non-invasive tools. We need to study the response to physiological challenges. I think it's important to kick the physiology, and that makes you a physiologist, not just somebody watching. And I think we need to integrate many variables. So this is Balloon Fiesta Week in Albuquerque. So if you're traveling through and if you could find a room, if you're traveling through and you can't find a room, call me. You stay at my place.